profile, and that way maybe people will be glad to see me when I show up. So. Well, thanks. Same here.
So, John's got you set up.
Yes.
He's staying to video, and I'm going to take him home afterwards. He's driven with me once before to do video for me, so he knows what he's in store for.
Okay.
He said his wife's kind of crazy with her driving, so mine didn't make him nervous at all.
Oh, okay. All right.
Like, you're too chill. What's up with this? But let's give it. What do y'all have?
Yeah,
5:26. So let's wait about 4 more minutes and then just go ahead and start.
Oh.
We think a couple are coming from CCU and CV also.
it does.
A lot of our new people haven't gotten down to this level yet to know where this is.
I'd never heard of it till we were walking over here.
Well, I don't get down here too often myself.
I feel like I'm underground.
And tomorrow we're back at the nursing place, right?
Yes. 7:15.
Are you on night shift? Like you used to be? You used to work here in this last girl. Gotcha. Oh, okay.
I have to get up at 4 a.m. to get here. Is it parking? I have to get here by 4 a.m. She's pregnant and her blood sugar's been adjusted her insulin. She's not been it. And her endocrinologist won't return her call. And the nurses there keep following her blood sugar. And keep telling her that they've printed it all out and put it on these stats because she's got the.
Dr. Blaylock, let's go ahead and get started.
Okay.
Just introduce yourself because we're recording you. They won't see you. They'll just see the PowerPoint, but they'll hear your voice.
Okay.
As long as you're talking through his mic, they
The
have to
microphone.
mic you up. So.
Right. Yeah. Yeah, it's on. Okay. Good evening. Thank you all for coming. I'm William Blaylock. I'm one of the non-invasive cardiologists with UT Cardiology, and tonight we'll be talking about some of the new developments in oral anticoagulation therapy. Can everybody hear me okay? All right, very good. This is very laid back. If you have any questions at any time, please feel free. This is an interactive session, low stress. So here are our objectives. We will review the history of oral anticoagulation as well as the coagulation cascade. I mean, everybody knows that anyway, right? The cascade. Okay. By heart, yeah, backwards and forward, absolutely. Because it's going to be a test on it. We will review some of the newer or novel oral anticoagulants. You may be familiar with them, and hopefully you will be more familiar with them and more comfortable with them after this talk tonight. And then we're going to review indications as well as contraindications for use of these agents. So a little history. This is from a journal article in the British Journal of Hematology. And I put all of this on here because we want to be sure we don't get in any trouble with anybody, because it's such a great story that I didn't want to leave any details out. So it all started back in the 1920s. Canadian prairies and the northern plains of the U.S. The problem was ranchers were noticing that their cattle were dying, and they were dying from some unknown internal hemorrhagic process. So through some detective work and deductive reasoning and maybe just a little bit of luck as well, they found out that the sweet clover hay that they were feeding their cattle, had been doing this for a long time, but this particular season or whatever, the hay they were feeding them had been infected by a mold. So after eating this infected hay, the cattle got sick about 2 weeks later, and within 1 to 2 months after that, they were dead of this mysterious hemorrhagic problem. So all they knew was, hey, don't feed the hay. If you got hay that gets wet, it gets damp, if it looks bad, smells funny, whatever, don't use it. And that's how they treated and solved the problem. So fast forward to about 10 years later. The pointer I usually use has the laser in a different spot, so I keep going to the laser spot on mine, which is not where it is on here. So.
Can you use the mouse if you point to anything, just so whoever's listening could see? Yeah.
You don't think they can see this?
They won't see that.
They won't see that? Okay.
See that.
We'll see it. Okay. Well, they should have been here. Okay, we'll leave the pointer off. So fast forward to about 10 years later. This guy, Ed Carlson, a Wisconsin farmer who was pretty much fed up with his cattle dying, as demonstrated by the fact that he drove, it said in the article, and that's why I put all that stuff up there, because again, I didn't want to leave anything out, said he drove 200 miles in a blizzard to get to an agricultural research station, had a carcass of one of his cows in the back of his truck. He also had in the back of the truck something very strange, and that was a milk can which was full of unclotted blood. So the fact that he could drive 200 miles in a blizzard and this blood never clotted is a big problem. So some dedicated researchers were at this research station in a blizzard when this guy gets here, and Carl Link and a student, Wilhelm Schoeffel, were there. So they take this stuff in and they start doing some investigations. And now it's 1941. And what they isolated from this infected hay was an agent called coumarin. Get the pointer over here. Coumarin, not a typo. So coumarin. And when this agent in the hay was oxidized, it turned into a compound known as dicoumarol. So a graduate student by the name of Mark Strayman was able to come up with a way to isolate large amounts of this dicoumarol so they could do some studies on it. And the work for this research was funded by the Wisconsin Alumni Research Foundation. Why is that important? Well, WARF, that's right. So that's where the name comes from. So they patented the rights to this agent, dicumarol, in 1941. In 45, this same guy, Link, was saying, you know, we could use this to solve this rat infestation problem we have. Because after all, it kills things by making them have internal hemorrhaging. So they were using it to kill rats. But the problem was that it was too slow. I guess by the time the rats ingested it, they could make 50, 60 more rats before they died. So it was too slow. So as a matter of fact, they continued to work on similar compounds, and according to the article, 150 of them they looked at, but it was number 42 that worked the best. So now here we are in 1948. So 3 years later, he finds formula number 42, which was named warfarin, after the Wisconsin blah, 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 and they patented it under the trade name of Coumadin, not coumarin, as the original compound was, that led to the dicumarol. So, continuing with the history, after they come up with this compound, they were using what's called a prothrombin ratio, which, has anybody ever heard of that? I haven't heard of it either. Okay, here's why. So, the prothrombin ratio was used initially as a way of monitoring therapeutic response to warfarin. But the problem was, using thromboplastin assays, these numbers were all over the place, because depending on what type of thromboplastin was used, the numbers were widely different. So it wasn't until 1982 that the World Health Organization, and again, not a typo, this is a British article, okay? So the World Health Organization in 1982 came up with the International Normalization Ratio, what we refer to as the INR, as a way of knowing that a number in Wisconsin meant the same thing as a number in California as a number in New York. So there was a way to look at this and say, if I've got an INR of 4, it means the same everywhere. Because previously with these different assays, an INR of 4 in one lab may be completely different from an INR of 4 in another lab. What's up, Jill? Thanks for coming by. Okay, she's here. We're going to start back over. So, as promised, the coagulation cascade. I'll give you a minute to soak that in, because remember, you will be tested. It took a long time for me going through slides to find one that I thought was adequate, because there were some that were crazy busy. A bunch of lines and curves and arrows and all sorts of things. But the bottom line is this. There are two pathways. One, the intrinsic pathway. The other is the extrinsic pathway. And the key point is they converge right here at factor 10A. So out of all these pretty colors and all of this stuff up here, all I want you to take away from this slide, and I'm a simple man, so I have to keep things simple. All I want you to take away from this is two pathways converge at factor 10A. I said I only want you to take one thing away. Okay, it's two. Here's the second thing. Thrombin. If you'll notice, thrombin is beyond the point where the two pathways meet. So you've got kind of your fork in the road at 10A, and then you've got thrombin a little bit beyond that fork in the road. And these two factors will be important for what we're about to talk about now. So, are there any questions so far? Okay, good. Get some liquid here. Yeah, and that's why I tried to find one that gave us the essence without the anxiety. And okay. So, some of these novel agents. The first is Pradaxa, and I've put these in the chronological order in which they were released. So Pradaxa, otherwise known as the Bigatran. FDA approved it in 2010 for the risk reduction of stroke in patients with atrial fib. Now, back on the previous slide, I showed you that thrombin is one of the important factors that we talk about here. And Pradaxa is a direct thrombin inhibitor. So it interferes with the function of thrombin, keeping it from going to fibrinogen and forming a clot. It's a twice-a-day agent. It starts out as a prodrug that is metabolized by the cytochrome P450 system to form an active drug. And I'll mention this cytochrome P450 because there's a little folklore associated with that. I went to medical school at the Bowman Gray School of Medicine, which later became known as the Bowman Gray School of Medicine of Wake Forest University, which was way too long for people to put on bumper stickers, so they changed it to Wake Forest University School of Medicine. But one of our biochem instructors, Professor Cornelius Strittmatter, may he rest in peace, was supposedly one of the guys that helped discover this cytochrome P450 system. So that's some additional history at no extra charge to you. So Pradaxa has a half-life of 12 to 17 hours, and this is important. We'll talk about that later. It's primarily excreted in the urine, and prior to the development and release of Praxbind, one of the biggest assets that we had with these novel agents was their short half-life. Okay? Half-life of warfarin is about 3 days. Half-life of these guys, think of it as 12 hours, because that's an easy number I can remember. So in 12 hours, half the drug is gone. Another 12 hours, half of what remains is gone. So in 24 hours, 75% of the drug is gone. Told you I'm a simple guy. I have to keep things simple. So our biggest asset was a short half-life, but now we have Praxbind, which is available to reverse Pradaxa. In addition to being used to reduce the risk of stroke in patients with AFib, it can also be used to treat and prevent DVT and pulmonary emboli, as well as prophylaxis for DVT and PE in patients who have had orthopedic procedures of knee and hip replacement. The next agent released in 2011 was Xarelto, or rivaroxaban. It also can be used for these same indications. It was first released, however, with the indication for DVT and PE prophylaxis in knee and hip replacement surgery. In 2011, November, so a few months after its initial release in July, or approval, then non-valvular atrial fibrillation, stroke risk reduction, came into play. And in November of 2012, they achieved another indication for DVT and PE treatment. Xarelto differs from Pradaxa in that Xarelto is a 10A inhibitor. Now, remember that's right at the junction of the intrinsic and extrinsic pathways. It's a once-a-day agent, so that's an advantage, because if you've got somebody on warfarin, they're used to taking it once a day, you put them on one of these agents like Xarelto that's once a day, and they can still wrap their brain around it. They're not feeling like maybe they're getting worse because they're on a twice-a-day medicine instead of a once-a-day medicine. It is also metabolized by the liver, by this cytochrome P450 system, as well as some other enzymatic pathways. And in young, healthy test subjects, the half-life was really short, 5 to 9 hours. In older patients, it was, again, roughly 12 hours. So the benefit to this agent is a very, very short half-life. With these agents, we don't have to monitor an INR, and I'll talk about that later. Does anybody know where the name Xarelto came from? How they achieved it? I'll give you a hint. Factor 10A, XA, Xarelto. So they probably paid some company a lot of money to come up with that. I would have done it for half. It has multiple routes of excretion: urine, and the GI tract. It has a reversal agent under investigation. Andexa. Look what they did again here. Okay. So the reversal agent is being investigated. The FDA has not yet approved it, but it's coming. So one of the advantages Pradaxa had was it has a readily reversible antidote, basically. And the 10As, like Xarelto, do not, but there is one on the way. The next one that hit the market is Eliquis, or apixaban. It was approved in December of 2012, again, for reducing the risk of stroke in patients with atrial fibrillation. 2014, the DVT and PE indication came online. It is also a factor 10A inhibitor. So it works right there at that junction of the intrinsic and extrinsic pathways. It is a twice-a-day agent. Metabolism is very much the same as it is with Xarelto. The half-life is very similar. The route of excretion is very similar. And again, because this is a 10A inhibitor, antidote or reversal agent, it will work on any 10A inhibitor. So it's not just specific to Xarelto. Anything that's a 10A inhibitor, this reversal agent will work on it. So I guess we'll be inhibiting the inhibiting agent, or we'll be reversing the inhibitor, or we will be inhibiting the reverser, or however you want to slice it, okay? The last one to the table is Savesa, or Edoxaban. January of 2015 is when that hit the market. Again, AFib, stroke risk reduction. It is a 10A inhibitor, like the Xarelto and Eliquis. It is once a day, like Xarelto. So we've already seen several 10As. One is twice a day, Eliquis. Savesa and Xarelto are once a day. It also is metabolized in the liver by that same cytochrome P450 system. Roughly the same half-life, about 12 hours. Pretty much the same method of excretion. Now, what are the indications for these agents? Well, we've already talked about them. DVT and PE prophylaxis in orthopedic procedures. Reducing the risk of stroke in patients with AFib. And by non-valvular, we mean patients that have atrial fibrillation not because of severe mitral stenosis, or patients who have mechanical or even bioprosthetic valves. So non-valvular. If you've got AFib for any other reason, then these agents may be a good choice for you. And we can also use these agents to treat DVT and PE both in the initial phases and long term. Now, one in particular, Xarelto, can be used in both cases, as the others can, but without bridging. So typically to treat a DVT in the hospital or pulmonary embolus, what would we do? Well, we give the patient heparin or Lovenox first as a parenteral agent while we waited and waited and waited for the INR to go out on the warfarin. So every day you come by and see the patient and you say, we'll send you home when your INR is 2. And it's 1.4 today. So they sit and they wait. And you come by the next day and say, we'll send you home when your INR is 2. And it's 1.6 today. And they wait, and you keep coming by every day, tell them the same thing until they're a little testy, you're a little testy, you're wondering how much longer is this going to take. So that's the old way we had to do things. With these newer agents, and Xarelto is one in particular, you can start right at the beginning, give them the Xarelto with no parenteral medication, because these agents also have a short onset of action, roughly 2 to 4 hours. So within that time frame of the first dose, the patient will be fully anticoagulated. And I make that a point when I put in my notes to surgeons that they want to stop one of these agents because the patient isn't having a procedure. It's like, look, don't start it back immediately. You have to get good hemostasis, because you can start Coumadin right away if you want to, and it's going to take days for it to become therapeutic. With these guys, if you have surgery and you give them one of these new agents, a couple of hours after surgery, they may bleed because they are fully anticoagulated fairly quickly. So we can use these agents as a method of single therapy to get the patients through the initial phase of their DVT and PE and to treat them long term. Any questions about the agents and their indications? Okay, good. So now we're moving to contraindications because, you know, everything has to be a balance. If I tell you why we're going to do something, then I have to tell you why we can't. So, number one, without saying the obvious, is active bleeding. If the person has had any type of reaction to the drug itself or something that may be contained in the drug, we can't use it. Significant hepatic disease. Why is that a problem? Right. These agents are metabolized in the liver, and if the person has significant liver disease, they may have a coagulopathy already. They'll be auto-anticoagulated. So, have to be very careful. It doesn't mean you can't use them. But if they have significant hepatic disease, then we can't use it. So, pregnancy. I tell the pregnant ladies I see in the office the only medication I will happily give them is a prenatal vitamin. Okay? Because anything else is a potential problem to them and the little person inside them. If renal function is significantly impaired, we can't use these agents. The cutoff is typically a creatinine clearance of 15 or less. There may be some information out there that says Eliquis can be used in the dialysis patients, but that was a very small study and it has not been widely embraced. So the take home with this slide, this portion of it is, if you're a dialysis patient, you probably don't need to be on one of these agents. If the creatinine clearance is over 95, we can't use Savasa. So that's kind of a mind-twisting thing here. But again, simple guy, have to keep things simple. Savasa is very rapidly metabolized, and if the renal function is too good, you won't get the bang for your buck you need. So some patients, I can't give Savasa because their renal function is too good. Sounds crazy, but it is what it is. If the person is going to have any type of procedure that is a spinal or epidural, for obvious reasons, if there is a complication, if there is a bleeding problem, there could be devastating neurologic consequences. So it doesn't mean we can't use these agents, but you have to be very, very careful. Typically, stop these agents 24 to 48 hours prior to the procedure. Give it a good 12 to 24 hours after the procedure before you start them back. If they have any indwelling catheters, like an epidural catheter for whatever reason, you're not going to want to have this agent on board and then pull that catheter out. You know, so you're going to wait 18, 24 hours from stopping it before you remove the catheter. So again, these are common sense kind of things, but it doesn't hurt to hear common sense kind of things. So, mechanical prosthetic valves. Literature is kind of sketchy on this. I don't think anybody is really going to be gutsy enough to do a controlled, randomized trial or whatever that says, you're going to get this and you're going to get this and I hope your valve doesn't clot off or I hope you don't bleed to death. So that's kind of been the problem with these novel agents, that they're really not indicated for a mechanical valve. There is still a place for warfarin in the world, and mechanical valves is one of them. And if someone has an acute unstable pulmonary embolus, so we talked about how you can use this to treat an acute DVT or PE, but if they are hemodynamically unstable, we're talking about to crash and burn, may need to go to the radiology interventional suite to get a thrombectomy or something along those lines, we're not going to want to give them one of these agents, particularly if they're going to be staring at the prospect of a mechanical intervention. Any questions? See, I told y'all this was going to be low-key. All right? So, in summary, because cows got sick and farmers got irritated, and rats multiplied, and through the efforts of some dedicated researchers, anticoagulation therapy was born. Warfarin is still #1 prescribed anticoagulant in the world, because there are reasons why people need warfarin. We already talked about one, mechanical valves. #2, if you've got a thrombus, like you have a big MI and you have a clot in your LV apex, warfarin is still the recommended agent. In patients who have valvular atrial fibrillation, that mitral stenosis person that had rheumatic fever as a child and developed stenotic mitral valve as a result of that, and then they got significant left atrial enlargement and they went into AFib, that person gets Coumadin. Someone with a mechanical valve, and then we talked about thrombosis type scenarios like an LV thrombus. Those people are warfarin candidates, not novel agent candidates. Their advantage is that we don't have to monitor an INR. And when you think about it, in most patient populations, that's very good, because though warfarin may be cheap as a generic, what is the real cost? You have to take time off work, or you have to have someone take time off work to bring you to the doctor's office. You may have a copay for the visit to get the lab done. If they don't have a Coagucheck machine in the office, you have to get a venipuncture, send the blood to the lab, wait for the result to come back, analyze the result, try and contact the patient. It could be days before you get in touch with the patient and make a meaningful change. With the Coagucheck machine in the office, finger stick, you get a number right there, and you can tell them right then, okay, you're on 4 milligrams a day, you need to go to 5 milligrams a day. Or you're on 4 milligrams a day, you need to hold for 2 days and go to 3 milligrams a day. So depending on how you can monitor that in your office will determine how well you can take care of your patient. But by the time you factor all of those in, if you can get warfarin at a generic price, when you put those other factors in there, it may not be as cheap as it sounds or as it seems. These new agents have fewer food-to-drug interactions and fewer drug-to-drug interactions. Think about it. You've all had patients, or you will have patients, on warfarin, and the minute they get started on the new medicine, their INR could go crazy. Some of the things we commonly see: you get a sinus infection and you get started on an antibiotic. You get a UTI, you get put on an antibiotic. INR goes through the roof. Very common. One of the commercials for Xarelto had Brian Vickers. Anybody a stock car racing fan? I wasn't, but anyway, so Brian Vickers is in this commercial, and it's one of the first Xarelto commercials. And he's driving down this long dirt road to this big picnic at a farm or something. So he gets out and he's yucking it up, he's talking to people, and they sit down to eat. And it's a very subtle thing. For those of us in the know, us medical people will pick up on it, but the average guy on the street wouldn't. But it's a subtle thing. He's sitting down and he has a big salad. Can't do that with warfarin unless you eat a big salad every day. Because patients say, oh man, I'm on this medicine, can I have my greens? Sure. You want to eat the same amount pretty much all the time so that we can monitor it better, because these green leafy vegetables contain vitamin K, which is the reversal agent for warfarin. So food-to-drug interactions and drug-to-drug interactions are far diminished, not zero, but far diminished with these novel agents. So to keep everything straight, we have to give references. So we already talked about the British Journal, not a typo, it's a British Journal, okay. If any of you have smartphones, you may want to download the medical app called Hippocrates. Anybody have that? You should get that. It's free. It's the only kind of app I download. But it is a wonderful app. You can look up medications. It will give you drug-to-drug interactions, the metabolism of that agent. Sometimes the cost is there. They have pictures of the tablets. So there have been times I've taken my phone out and the patient says, well, I'm on this, but I don't know what dose. Here's a picture. What does it look like? It's the green one. Okay, thank you. So it's a very good app, and if you don't have it, you should really look into getting that. The Coagulation Cascade came from the website here, the Clotting Cascade GIF, if you couldn't figure that one out. And the Big Finish. Any questions, anybody? Yes, ma'am.
When can we expect the Xarelto reversal agent to be available?
That- That's a good question, because it seems every time this 10.8 reversal agent is about to hit the market, the FDA says, we want to see some more data. So Xarelto, Savesa, and Eliquis, they're all asking their respective companies to provide more data. So who knows? Who knows? So thank you for your time and your attention. Go Heels. Graduate of UNC Chapel Hill, me and my wife. We've got a daughter that's a junior there. And my younger daughter will be a freshman at Kentucky. So I have to get used to a darker shade of blue. Like this is all Kentucky blue right here. I'm getting used to it. It's not Duke blue, which is a good thing, but it's Kentucky blue. So again, thank you for your time. I appreciate you coming out. If there's nothing else, we'll call it a day. Thank you.